So one of the things we're coming to session 4, and this is about NHS and technology. I'm chairing this. I'm Richard Morris. I'm the mood disorder theme lead from MindTech. So I'm a psychiatrist by background, and with quite an interest in implementation. And the session is called From Clinically Driven Needs to Implementation. I think what you're actually going to hear is a story, a very interesting story of co-production from an NHS service, and I think it's best that they tell you about it. And then something much more perhaps driven by the people themselves and less directed by clinicians altogether. But without any further ado, I'll introduce the first set of speakers.
Would you like to come up? Hello everybody, my name is Simon Thomson. I'm up there, Principal Psychotherapist, Eating Disorders Service Manager, which means 2 headaches for the price of 1. This is Deighton. Would you like to say?
I'm the peer moderator on the SHaRON moderating team.
So SHaRON basically stands for Support, Hope and Recovery Online Network. Okay, so if we just go through it, this was a development that we started working on 6 years ago in Berkshire in eating disorders to think about how we best support people in the community, out of hours, and also after they've been discharged. And building on the idea of years of me working with patients, them recovering, getting themselves better, saying to me at the end of a session, is there anything I can do? I really want to stop people getting to this stage. I really want to help other people. And I had to say to them the usual jargon of, that would be great. Please go away, get yourself trained, and come back in 5 or 6 years. And if we have got a space for you, I would love to employ you. Now what we were able to do is we were able to use all that experience, expertise that was just walking out that door, and use it to actually provide a moderating on a social networking platform for people who are referred into the eating disorder service in Berkshire, to support them and aid them during their treatment, supported by clinicians and also supported by the peer moderating team. So we operate as a moderating team, clinical and peer. And also whenever they're discharged from the service, but they're not ever discharged from SHaRON. They stay on SHaRON as long as they want to. So we'll just run you through this. So they come in from their referral from the GP, they have an assessment, 10% might go to hospital, 9% go to day program or outpatients, discharged to outpatient service, discharged, 30 to 40% are re-referred back into service. That's a national average for eating disorders. So basically people going out, treated, coming back into the service because something in their life has happened, as it's triggered off their thinking, which then affects their behaviour and the mood. They relapse, back to the GP, back to service. So what we did was, with the introduction of SHaRON, we have significantly lowered that rate. Now all these slides, or most of the slides, come from research that was done by Johnson, an independent piece of research looking at SHaRON and what it actually has achieved, because over the last couple of years doing presentations to people, different audiences, and whenever they asked about that number, and I was saying, well, it's a handful, they were going, well, that's wrong. Well, I had to say, I'm sorry, but that's what I know is the figure. Anyway, it's nice to have it proved. So basically that's SHaRON. So self-referrals we get in, people are referred in, we send them a questionnaire, and the questionnaire has asked them if they would be interested in joining SHaRON. If so, then provide their email address, it comes back to us, we can then provide them with an invitation to become a member of SHaRON before they actually have any contact face-to-face with our service. SHaRON is like a big building, and in that building there's lots of different rooms, what we call subnets. Each room is specific to a type of presentation with eating disorder SHaRON. So anorexics will be in one room, bulimics in another room, binge eating disorders in another room, relatives, carers in another room, and people coming into the service who we haven't seen yet in another room. And they can't interact with each other, they can only interact with others around them of the same type. Home treatment, so we've got a home treatment team that's been working now for around about 2 years. That's very much linked up with SHaRON. We can monitor people in their own homes, and we can do Skype with them, and we can have messaging with them. A lot of that contact is carried out through SHaRON as well. Okay, patient-centered innovations, co-produced and delivered with patients. Right from the very, very beginning, idea in my head, talk to patients. What do you think of this as an idea? Would it work? What way would it work? How would it work? Best colour? What sort of text to use? Right down to sort of how it would look. So how comfortable they would feel using it. All the way along, involvement. We ask for feedback, we get feedback on how much they experience the benefit of the site or not benefit of the site. The moderating team meets once a month online in the evening. We have a discussion, making sure that they get the support they need in case anything triggers them. And again, and that's fed back to the web team, who will then develop certain parts of what people are saying, it's not quite working, or we'd like it like this, or we'd like it like that. So there's a real sort of process of involvement of our membership to ensure that what they actually buy into is fit for purpose. Okay, so basically that's just more and more. I realized when I was sitting up in the earlier session that people are really rushing, and I was thinking, I don't want to rush. Because this is about.
You aren't going to have to.
Yeah, I know that, and they're rushing off. Okay, so basically, yeah. So I'll just very, very slowly rush through it. Okay, so interestingly, one of the things that we do is that we could go to the live site. Obviously, we can't at the moment, but we could go to the live site because whenever members are invited to join, they're asked to create a username for the site, which keeps their real name anonymous. So all you would see is something like glitterbug, daffodil, rosebud, or various other lovely names they give themselves, and you would have no idea who they were. And that's really, really important because they then feel that they're comfortable and they're safe and they're secure whenever they're online, and they're protected, their confidentiality is protected, and obviously at what's called the back end, unfortunately, which is to make sure that it can't be hacked into. There's two databases. There's a database of the names and databases of the email addresses. And the names are not linked to the email addresses. They're stored separately. So in order to make any sense of if anybody actually got onto the site who shouldn't be on there, you can only get on there if you've been referred to the service. But if they happen to get on there, they wouldn't be able to make any sense of it anyway. So it's NHS, clinical governance, really, really important because it's the NHS. It has to be ultra, ultra safe. At 6 years, we work really, really hard at it, and we have not had a breach of the site yet.
Sorry, 1 more minute.
1 more minute. Okay, what I'm going to do is I'm just going to hang you over to Els just to talk about her experience. She was a patient in treatment. She was a member of SHaRON, and now she is a peer moderator.
Thank you, Simon. So yes, this is a real life story of how SHaRON really can help me and lots of other people like me. I joined SHaRON as a member in April last year when I found that things were slipping backwards for me. And immediately it was helpful because I could put comments on there that, as Simon has said, I knew were totally safe. It was never going to get out there. I got constructive comments from other people who had genuinely been through the experiences that I was going through and understood what was happening. And it also felt very safe to share my thoughts and feelings. But while I was doing that, I also found something else. It was actually very helpful for me to think about other people's problems when they were posting the issues that they were going through. I could take a step back and have a think and think, how could I help that person? And in doing that, that made me think a bit more about myself and how I could help myself. So very rapidly, SHaRON really helped me, and quickly I became a peer moderator. Now, a peer moderator gives me access to all the threads through the site, so I can help people with anorexia, bulimia, etc. It also means that I need to be monitoring what people are putting so that nobody puts anything triggering. Nobody ever does deliberately, but sometimes that happens. But I also find that it really does continue to help me. It's also very satisfying because I've gone through an awful lot of really bad experiences for me, but it feels now that actually I can make that a bit worthwhile because I can help other people because of the experiences that I've gone through. And the final thing I want to say is that it actually feels really great to be part of a team because I know that the clinical moderators who are on SHaRON can help people with all the knowledge that they've learned over all the years of training, but I feel that as peer moderators we're also very helpful because you can't really beat real life experience. Thank you.
I'm going to, so that we keep on track, I'm going to just pass straight on to Victoria and her team.
Okay, we're going to be really pacey as well, not least because Sue has a train to catch and she might miss it, so we are going to have to go quite fast. I just want to start by thanking MindTech for inviting us to speak this afternoon and also to say happy birthday. I'm one of those stalwarts that have been here from the very first MindTech symposium, and it's just amazing to see it grow and develop and get better and better, so congratulations. Anyway, co-design has popped its head up quite a bit today, and it's great to follow on from that presentation where co-design has clearly been a big part of things. We'd like to share some thoughts with you about digital innovation driven by people, and by people I mean patients, citizens, health and care practitioners, because we believe that's fundamental to doing this stuff well. I don't think that's a very radical belief, but we'd like to share a few thoughts about the how you do it well. So just to introduce ourselves.
I'm Sue Sibbald. I'm a peer support specialist for Sheffield Health and Social Care Foundation Trust, working with people and their families with borderline personality disorder. I am also on Twitter as BPDFFS, and that's Fighting for Services, if you're wondering.
So she claims.
And I run an online tweet chat on there for people with BPD each Sunday.
And I run a digital programme in the NHS called mHabitat. That's us looking quite happy. That's quite rare. Most of the times we're scratching our heads going, how the hell do we do all this stuff in the NHS? That's our model, which I won't spend any time talking about. But I just do want to talk very briefly about co-design, because we're really interested in how you do co-design well. Geraldine, if you remember right at the beginning of the day, name-checked Happy Vault, which is a digital tool that we're building that's emerged out of a digital innovation lab with a group of young people over the last 6 months. I do not believe in a million years that clinicians would have come up with Happy Vault, but when they pitched the idea to the clinicians translated it into, that's relapse prevention. So that was a lovely bit of serendipity. But I think young people in that instance coming up with the ideas, solving the problems that they wanted to solve was really, really powerful. Okay, so we ran an event back in May where we explored the question, how can we unleash people-driven digital innovation? And we had the event, and there are a few people here who came to it, because we were struck by a lot of industry events where industry had the stand. You might get the token patient coming up and saying a bit about their experience. That hasn't been the case today. It's been a really good mix. So we wanted to get people accessing services, clinicians, citizens along to that conversation. We had 100 people there, about 500 people on Twitter, and we ran it as a participant-led day. I'm going to share some of the key, very high-level themes that came out of this day, and then Sue's going to share an initiative that we funded as a result of the day. We didn't want the day just to sort of stop at the end, so we managed to get some money from Comic Relief and Big White Wall and other good people so that we can fund some conversations that come out of the day so that they could turn them into something tangible. So, as I say, I'm going to briefly touch on the themes from the day, but if you want to read more, we did produce a paper that came out of it called People-Driven Digital and Wellbeing, surprisingly enough. And I guess the challenge that we were thinking about came out of Personalised Health and Care 2020, which was referred to earlier on by Alexia, and just this notion that solutions and services must be designed by service users, carers and care professionals and not by technology ideologues. So we were sort of grappling with that notion. So that's Jeremy Hunt, if you can see at the top, looking a bit miserable with the bottom-up social movement. We had a graphic recorder, and that was his little interpretation of that conversation. So the really simple and obvious thing is that we just need to recognise and understand that there is this groundswell of people accessing services, interested in digital, who want to leverage it and want to get engaged and involved, and are often entrepreneurs themselves. Organisations need not to own it, but they do need to support and enable it. We talked a lot, and this has come up, hasn't it, today, about digital literacy of health and care staff, about reluctance. So there was also something about how do you join up the dots, and there's a lot of dot joining up today, and we need to do a lot more of it. Of course, the principles of co-design, collaboration, co-production, whatever you want to call it, bringing people together as people to collaborate is absolutely key, and that's when you get really good stuff happening. And again, we've touched on interoperability, integration, all of those challenges I know that all of you will be grappling with. We do need to get some of the basics right, and obviously the NIB work streams are working on those issues. And innovators were telling us, and I'm sure all the innovators in the room will say the same, is that we've got these good ideas, but how on earth do we engage with clinicians, with professionals, with NHS organisations? So we need to get that support in place. This is just a lovely, hopeful quote from Catherine Howe, who said there are signs that the system is ready to be disrupted. So I like to put that in there just to try and make it happen. And I guess that's all I'd like to say about the event itself. But what I'd like to do is hand over to Sue, who's going to talk about Flourish, which was one of the initiatives that we funded.
Yes, there were a few of us got together in Sheffield, and that included people like James from Patient Opinion, Tinder Foundation, people who use services, and there was also someone from the university. So there was a group of us all just got together one day, all happily. And what our purpose was to explore together the potential of digital resources to support people living with mental health conditions to recover a life. So where did we start? We started at the bottom. We started with, what do people need to live well? And as you can see, for people that could be anything. There was one guy there who didn't know about digital, but he realised he had a digital radio, which was something that helped him with his well-being. People talked about their self-worth. People talked about baking. People talked about lots of different things that kept them well. And I think that's key, really, to be thinking about well-being. And lots of course, there's Twitter and Facebook and social media on there as well. But we looked at that because we thought that was key. Then we thought about what gets in the way. What gets in the way for people with mental health conditions? Complexity of buying devices. You know, we all go, and, what phone am I going to buy? I don't know. You know, there's hundreds of them. Concerns over overwhelming massive information, particularly social media and managing time spent online. And I know I've had to curtail my time spent online because it's not been good for my mental health. Concerns about being safe and healthy online. Difficult to find out about useful and quality digital resources which fit with interests and needs. And lack of confidence, skills, taking the first steps. And that was quite a big thing. People just didn't know, you know, they were afraid. We may be talking, or I've heard today people talking about things on my head and things I'm going to wear on my fingers, and people are afraid of these things. So, digital action plans. We decided to do digital action plans, and everyone did a digital action plan. And that's what I liked about the day, because James from Patient Opinion, he did his. It was a flat platform. It wasn't service user dragged in, because that's not collaboration. Collaboration is everyone working together from all parts. We looked at learning, sharing and trying. People wanted to buy devices and internet access packages. Being safe and healthy online, people wanted to find out about that. People wanted to find out about social media. I wanted to find out about Instagram because I work with a lot of younger people and I thought I'd better get down with the kids, really. Mental health related digital resources, so they wanted to know about these because obviously there's 165,000 mental health apps out there, I did read the other day. Education and employment related digital resources, and that was interesting to me. People wanted to know about education, employment, not just CBT and all those other things, but things that really mattered to them. So the next steps for us have been to try out digital resources and other activities. We identified at the initial event, so people went away and tried out these things. We organised a learning session on buying a device and using social media and being healthy online, so I ran that session for people. And then we're producing a paper with our findings to share with others. And we're presenting back to Victoria next Thursday, so I'll be doing another presentation then. But what I found about it, one thing I'd like to you to take away from this is you need to think about those people who are digitally excluded, because there's a very lot in mental health, and you need to find how to include them and find out what helps them in their day-to-day life with their well-being, because that's what we want. It's about our well-being, and if not, you might as well not bother. Thank you. On that
Okay, so do you want to stay there just for a minute? Because you've used your time so efficiently, we actually have time for a question or two.
Train.
Can I just ask a question as I've got the microphone? I'm going to get privileged. It was actually to Simon and about, I don't know if it's okay to, as we didn't get a chance to ask questions about that. I'm Jen from MindTech.
Yeah, by all means.
I just would find it really useful for you to say what the biggest challenge was in getting SHaRON set up and how you got over it.
The biggest challenge would have been the reassuring the organisation that it was going to be safe. Because on the one hand, it's digital technology, which is, you're talking about 6 years ago, was a big unknown to everybody apart from younger people. And also that eating disorders is the highest mortality rate of mental health disorders. So it's a high risk area. And we were saying to them, let's just open the doors 24/7 and keep our fingers crossed that nothing happens. And so that the process of actually being able to reassure them and put all the clinical governance in place to allow them to actually feel secure that they could actually back us in what we were doing, I think that was the hardest part.
Okay, so I know you've got to go for your train. Can we have just one question as the first person? See, and then
very quickly. One of the things that's gone through so many of the presentations for me today is the idea of community, and yet nobody has really used that word.
Nice.
SHaRON is a community. You describing communities. Technology has the opportunity to bring people together in communities, but also I take your point about people not having access to it.
Yeah.
I'd love to hear more about these community constructions rather than the technology, because that's what's important.
It is.
Thank you.
Okay. Thank you very much. Yeah, sorry, you want to answer?
I absolutely agree with you, and I think we tend to talk in the NHS a lot about how technologies can keep people away and contained and separate, but actually a lot of the technologies are around building communities, particularly how people have leveraged things like Facebook and Twitter and blogs to make connections and talk about their lives and self-mediate their identity. So I think that's, for me, that's a really, really interesting point. Thank you.
Yeah.
Right.
Okay.
Thank you very much.
Thank you.
Thanks. I'd just like to reiterate that last point. I run in my clinical practice services for severe mood disorder, and that also has a high risk group. I've often thought the reason that I've not had any suicide or serious events has been because in this community of digitally connected people, and in other ways through psychoeducation groups and so on, they keep each other safe. But anyway, I'll leave that thought.